So I'm going to go through the acute phase again, since I feel like I kind of lost y'all in that lecture. And just remember that you have the pre-hospital phase and then you have the emergent phase. The emergent phase is from when the person arrives to care until that fluid shifting, electrolyte changing, the life-threatening issues are resolving. And they're starting to get that extracellular fluid back into the vascular system and that starting to mobilize that fluid. So that's when the acute phase starts. It can begin anywhere from 48 to 72 hours after the burn, and it continues until, excuse me, the rehab phase, which is when the person's wounds are starting to stabilize. The acute phase, this is when the person really is becoming more aware and things are starting to normalize for them mentally also, and they're starting to become more alert and aware. I added something to this slide, which is a YouTube video of Alison Masari. She's a speaker that I saw last spring at the Critical Care Nurses Convention. And I tell you, she had 8,000 nurses on the edge of our seat. So she was a burn victim. In 1998, she was hit head on, and she was in a car while the car was on fire, and her seat melted into her skin, and she thought she was going to die. But a passerby who was, it's just an amazing story, and she doesn't tell it in this video, but rescued her, pulling her through the window, and everybody thought she was going to die. So she went through the healing process for months and years. And this is her speaking to healthcare providers, and it's just a short one. They spend too much time talking about her. So it's much better if you ever have the chance to hear her, please do. And she has other videos up there, but none of them really are directed toward the healthcare provider except this one. But I put that up there because the emotional support as the person becomes aware of what's occurred and as they're trying to cope is huge. And she talks about how she could only think about seconds at a time. She couldn't even plan moments or days. And so for us, living in the world, trying to connect with this person who's in this place, we just want to tell them that that we're here with them, that we're providing care to them, that whatever they need, if they could let us know. So this isn't the time to plan things and to tell them lots of things because they're dealing with such excruciating pain. And so the debridement process and the wound care process is very, very painful. So our role is supporting them and their family and as they are becoming aware of what's going on and teaching them just in small little parts that they can handle without overwhelming them further. And we also want to prevent complications. And I know you've had a lot of education about what complications are usually preventable, such as preventing pneumonia by using centispirometer, preventing DVT and ulcers by using medications and leg squeezers and such. And that's going to have to be adapted to a person with a burn because just depending on their location of their burn and the severity of it. But we still want to include those things and also GI prophylaxis as much as we can get that GI system, have it retain healthy cells and function is going to be good. And certainly prevention of infection is a huge, huge issue with burns. As we talked about skin being the main protector against infection in our body, the barrier between our inside and the outside world. Losing that puts this person at huge risk. But not just that, keeping their bowel and bladder clean of infection can be very challenging with the mobility and issues that we've got when our attention's elsewhere. These things can occur. So and skin also, keeping whatever skin is intact at the time of injury, keeping it healthy is a really important thing for us to think of in our plan of care for this person. The most common cause of death after that 72-hour period, when they get into the acute phase, they've through the life-threatening phase, is infection, and you can just imagine why. So we're going to be assessing our patient for signs and symptoms of infection, not just of the odor exudate, but systemically. Now remember that they take a big hit immune-wise, so anybody with an immune system compromised, like a person with severe burns, if they mount a fever at all, we're going to have to pay really close attention to that, because a little fever in an immune compromised person is a sign of a bigger problem, like an iceberg, kind of. So this person needs to have nutrition supplied in some manner. And great if we can put an NG tube in or feed them enterally. If they can take food, that would be great, the best. And but whatever way, whether it's TPN or enteral feeding, we need to make sure that they have a good diet to heal all the wounds that they have. And then pain control. Allison talks about in her video how excruciating it was for her to go through the things that they had to do because that plastic seat melted to her skin. They had to go through and debride that area and pull out all those pieces of glass and such that were in there. But then after that emergent phase, then there's also the daily whirlpool baths and dressing changes and debridement that this person has to go through. And so we want to provide pain control. Granted, when they are very hypovolemic, it's a challenge to provide pain control because of the way that narcotics will depress the blood pressure. But in this acute phase, when we've started to stabilize them, this needs to be a high priority for us. Now, we're not going to be able to eradicate pain in this patient. And we usually will ask our patients, where would you be comfortable with your pain level? Thinking 2, 3, 4. We may not be able to get a burn patient's pain below 8 or 9. But we want to still connect with them and keep them involved in the plan and provide pain medicine to them without any judgment on our part, without any kind of withholding, and but we may not be able to eradicate it. But we want to medicate them before dressing changes, especially, or physical therapy. In this one of her videos, or maybe it was from the speech I heard, Allison talks about how her right arm, she had contractures so severe from the scarring from the burns that she could only move it 3 inches, and how physical therapy worked with her every day to increase that, and every day was a 1/4 inch improvement, and that alone was painful. But what would happen was her skin would break open where it was trying to heal as they worked with it. It tried to heal the next day, and they'd break it open again and trying to heal the next day. So it was a constant painful situation. And nurses can have a big effect, and we can't always relieve pain, but we can acknowledge the person's humanity and dignity. So anyway, and then wound care. Oh gosh, with this person, you want to be so aseptic. None of this clean dressing change. No, completely sterile dressing change, because they are so at risk. Really, wound care in a burn patient is a specialty unto itself. So if you are lucky enough to go have a unit where you can work with burn patients, then you're going to learn this. They're going to train you. So we're going to look at how we take care of these people, and really very early, as what happened with Allison, there's going to be a debridement or a surgeon usually coming in to take off the necrotic skin and try to promote epithelialization. So some of it, as we were speaking of about the layers of skin burned, depends on if those skin regeneration cells are still viable, and if the person can regenerate their own skin, that's optimal. But when you have 3rd-degree burns or 4th-degree burns, that is no longer possible. And so what will happen is they'll do an escharotomy, where they go in, and that's the yellow arrows, where they will release the skin so that it's not so tight, and that the healing can occur from the person's own methods. And the other thing that they'll do, besides debridement, when they remove the tissue, is they'll graft. And if a person has large areas like their legs or their back, or areas where they can remove skin, the person's own skin, and graft it onto the burn area, that's tolerated the best by the patient. It's very painful, because look, they've just removed skin from another area, and that area is going to be painful too. But that's the best. They just remove the top layer of skin and place it over with, like as you see up here, the mesh over it to try to promote healing. And then there are dressings that will put on the topical agents, such as Silvadene, that can be used. Then there are other burn wound dressings that such as silver impregnated or a special calcium alginate that they can put over the burn areas, and of course to prevent infection in those areas. So as I said, strictly sterile dressing changes. There's a video that I put up here which is just amazing. I hope you'll take the time to watch it. I wanted to show it during class. I ran out of time. It's just about 2 minutes long. It's the film by National Geographic about this guy that I called the burn gun, but he calls it the skin gun. It's where it shows a firefighter who was injured, not in a fire, but in a, like he was at a barbecue or something where somebody poured gasoline on the fire and the fire roared up and it burned his side of his neck and his shoulder and his arm. Second-degree burns, and I don't know if there were third-degree burns in there, but it shows him 4 days later completely healed. And what this skin gun is it takes like a little bit of the skin and it sprays it over the wound area so that that person can regenerate their own skin. It's just amazing. And actually, they're trying to get this approved. This sort of hit a bump in the road because this video is from, I think, 2011, and it still hasn't hit the market yet. But it shows hope out there that people wouldn't have to go through these excruciating skin grafts and constant dressing changes and debridements. So the Whirlpool is used to debride and cleanse the skin, and we want to premedicate the person before they go into this. A lot of times it's done, in regular hospitals, it can be done by physical therapy. I'm not sure about in a burn unit if the nurses are doing it. But we want to allow for rest periods and look for, after the debrided skin has come off, look for what the skin is looking like. Is it scarring? Is it showing granulation? And then when an area that's been decided is not going to heal on its own is ready for grafting, that's when they'll graft it. And so nursing considerations, the person is going through a lot of psychological things in addition to their physical, as we spoke of. Maybe giving them control over their pain and their pain medicine would be a great situation, like using a PCA. I don't see PCAs used as much as what we used to use them all the time when they first came out, and I'm not sure why, but advocating for that so that there's not like this long delay before the person gets medicated when their pain is out of control, because these people have constant pain. And then if we're going to do something in addition to what, their underlying constant pain, in addition will cause them more pain, then they need to be able to get medicated. And if they're not able to do that themselves, then that's when the nurse should be doing it. But if they are able to, as a person, knowing that there's relief for your pain, that's part of the relief of the pain medicine. So giving them that will help them and keep it under their control, which, as we try to move them back to being independent, having them take control of things is a really important thing. So those are some of the issues. We can give them additional, like sometimes the PCA will have like a basal rate, and then in addition to that, the patient will be able to add additional medication in that. And then in addition to that, sometimes the doctors will write for breakthrough that we can give them a bolus in addition. So that's how we could advocate. And then the, general psychological implications of any long-term chronic or debilitating illness that has these kind of things is the self-esteem or the person's their concept of their own body and the grieving of the life that they were living up until that injury, and how things have changed now and how people react to them. So some of the scarring and the injuries are horrific, and people react really sometimes negatively. That's one thing that Alison talks about, is she was shocked at what people would say to her, even nurses, the things that nurses would say. So trying to help the person as they adapt and adjust to the way that life has taken an unusual turn for them. And Then making sure that they have the calories needed to do the healing. So this is talking about a MediHoney, the different, these visual pictures are talking about the difference in the healing process and in an optimal situation. And then rehab, the goal is returning the patient to their life, however they want to choose to live it, being independent, productive life in whatever way they describe that. So mobility limitations can be severe. Even after the injury, they can have the contractures and scarring, and that can limit their mobility. It can cause them to have increased risk of poor outcome from decreased mobility. Maybe they don't want to go out in public, or maybe they have pain with their mobility. So trying to work with them with a plan and following up once they are discharged from the hospital with physical therapy and nursing, promoting exercise and care of their ADLs. So, and then the patient and the family needs to know how to care for the wounds and the dressings. They need to know when to seek medical help. So, for example, if they have signs and symptoms of an infection, they need to return or call their physician. How do they exercise? How do they follow up with their physical therapy, with their active range of motion? What type of clothing restrictions might they have? We don't want to have, sometimes if there's a injury to their abdomen or to their arms or something, clothing will irritate that area. So how do they do that? And then social skills, talking with them about ways that they can, work with what's happened to them. Maybe they could use some different wigs or other things. There are people, and also connecting them with social support groups for people that have had this. I know Allison has a camp for children that have suffered burns, and where they try to help kids cope and just give them experiences away from the public's eye. Well, she talks about this little boy that was burned at age 2, had a Bic lighter in his closet, and she had him in her burn. She heard about that before she was ever burned as a young person, and she had him in her burn camp, and she didn't realize that it was the same boy. But one day, after she had known him for some time, and he was such a vibrant force with such a smile, and just brought such energy to whatever he was doing. She asked him how he was burned, and he said, "Did you ever hear about that 2-year-old that had the Bic lighter that caught himself on fire? That's me." And so that social network of people that have gone through these life-changing events can help a person develop some skills and feel like they're not alone. And that's the end of that part of the lecture that I wasn't able to conclude in class. Thank you.